Thank you, Professor Richard McManus, for your kind introduction. Am I audible? Okay. And of course, thank you everyone who has joined this event, my friend, my colleagues, and also many people I don't know. And I would say I'm pleasantly surprised that death is such a popular topic. I didn't expect that. I'm especially humbled by the presence of my mentor, who actually transformed me from a medical doctor to a medical anthropologist, Professor Emeritus Sjaak van der Gist from University of Amsterdam. Thank you, Sjaak, for flying all the way from Amsterdam. I take comfort in the presence of my wife, Dr. Paprin Nahar. She is also my companion in the journey into medical anthropology. I must admit that I'm a little bit nervous because my two sons, Nior and Shair, is here. They have never seen me lecturing. The question, what is good death? Those who are not in the field of death, dying, and end-of-life care, this might seem a very strange question. No death is a good death. But before I talk about good death and my argument about it, I would like to take you through my career journey, which will explain actually how I got interested into death, dying, and also decolonization. And because this talk is about me, I hope you will kind of allow me to engage in self-reflection. So I started my journey as a medical doctor in rural Bangladesh. The villages in Bangladesh also felt like a different world for me because I was born and brought up in cities. Freshly graduated from medical school, I was eager to apply my knowledge on complex diseases. But I was confronted with harsh realities. The villages I was serving were suffering and dying from very simple preventable diseases like diarrhea, pneumonia, which the anthropologist Paul Farmer would call stupid deaths. 3 decades back, Bangladesh actually had one of the highest infant mortality rates. And so moving through this green village, I often saw graves of small babies. I would like to tell a story of one such death, of course not a good death. So this is a grave of Abu, a boy who just lived 4 days. Like many others, the family buried him in the backyard. So I talked with the mother and wanted to know what had happened. And so this mother, a young woman, lives with his husband and in-laws, belonged to a very poor family. So when she got pregnant, she wanted to get a vaccination, but there was no hospital or health center in the village. So she convinced her husband to take her to a nearby satellite clinic in a village, in another village, where a government health worker comes once in a month. So they went to the health center, waited for the whole day, but the health worker didn't show up. So she didn't get the vaccine. Abu was born at home with the help of a traditional birth attendant, an elderly woman who performs different birth rituals and cut the umbilical cord with a knife made from bamboo. So everyone was celebrating Abu's arrival, but after 2 days, Abu developed high fever and his skin turned blue and red and stopped breastfeeding. So the mother pleaded to go to the hospital, which is 15 kilometers away. But the grandfather stopped because hospital is expensive. You'll have to buy everything, and it's untrusted. Instead, the grandfather started reciting from the Holy Quran, prayed for the whole night, believing that this will cure the baby. When that failed, they called a traditional healer who gave some herbs, but Abu's condition deteriorated. So they decided to go take the baby to the hospital. But it took some time for them to collect money from the neighbors, from the relatives. And then finally, they set off for the hospital with a rickshaw van in a rough road. And on the way, the baby died. Now, from my medical knowledge, I know that the baby died from neonatal tetanus. But this was not just a death. It felt like it was a murder. And then I asked myself, who is the killer? So the death certificate says that it's the tetanus. So of course the germ is the culprit, one of the culprits. But Abu's death could have been prevented if the mother had the vaccine or the birth was attended by a skilled attendant. So that highlights the fault in the health system, which is also a killer. If the mother had the power to make decision to take care, take timely care, maybe Abu's death had been prevented. But in that family, it is the father-in-law who makes decision. So this unequal power relation is also a killer. With deep love, the grandfather prayed for the whole night and relied on prayer, and then later on with the traditional healing. So these cultural practices and health-seeking behavior, although meaningful, was ineffective for tetanus. So these also played a role in Abu's death. And then not having money delayed the decision for taking timely medical care. Making poverty is also a killer. And then finally, absence of ambulance, bad road, and this infrastructure played their role too. So as you can see, there was not just one killer. There are intersection of multiple killers. It's like Agatha Christie's stories, Murder in the Orient Express. So, and what I realized that disease is just one aspect of this death, one factor behind this death. And with my extensive knowledge in medical science, I would not be able to prevent death of another Abu unless all these social, political, cultural, and structural factors are addressed. And this experience in my early career pushed me to think beyond biology, beyond medicine, beyond hospital. And that actually drew me to public health and then later to medical anthropology. I mean, a career path hardly any doctor in Bangladesh would consider. My medical friends and colleagues were quite surprised that I'm joining the aliens like anthropologists. And I felt always misfit between anthropologists and doctors. Yet I embraced this path, and I think I'm inspired by Robert Frost, that two roads diverged in a wood, and I took the one less traveled by, and that has made all the difference. For my PhD, I focused my interest on the hospital itself, where I was trained as a doctor. And that hospital actually didn't prepare me for the medical reality of the country. So I wanted to have a fresh look to the institute. And I did an ethnography of my own tribe, which is doctors and like medical professionals, within my own village, which is the hospital. So in anthropological term, I was native among the natives. As the anthropologist Sri Nivash would call, I was actually thrice born. First being my biological birth, second by training on anthropology, and third, looking at my own culture and own profession with the lens of anthropology. And what I realized through this study, that although biomedicine and hospitals are considered as cosmopolitan and universal discipline, these are highly localized in terms of practice. And I showed how the broader values and norms of the broader society is played out in the hospital. And my ethnography actually showed hospital as a microcosm of the bigger society. And that intrigued my interest in the interplay between universal and particular, which actually shaped my works in the later part of my career. After finishing my PhD, I played a crucial role in establishing James P. Grant School of Public Health, Brack University, Bangladesh. This was acknowledged by WHO as one of the innovative School of Public Health from Global South. I coordinated this school for 5 years, and then the school was about to promote me to professor and the head. But as Biddle remind us, life is what happens to you while you are busy making other plans. And with series of turns of events, I found myself in UK as a postdoctoral researcher in a global health project. But this transformation exposed me to a number of challenges. In Bangladesh, in a so-called country in the periphery, I was in the center of academic and professional world. In UK, in so-called country in the global center, I became a peripheral figure. My colleagues became like, couldn't tell whether I'm from Sri Lanka, or Pakistan, or India, because it all looked the same. But we all are product of our history. So I come from a country that's the only South Asian country that gained its independence through a liberation war where millions of people died. And the Bengali language was central to this fight. And growing up in the post-independence period, we were discouraged to speak any other language than Bengali. So as a result, my English skill was weak. Still it is weak. I have written several books in Bengali. I play with words in Bengali, but I still struggle to find right words in English. So living here, I understood how Europe is not just a geographical space. It's a mindset, and that sees itself as the standard and the universe. And I became the other and experienced how the identity is being fractured. And also I learned about double consciousness by Frantz Fanon, but I experienced it myself. I felt like I'm playing the childhood game of snakes and ladder. So when snake bites the dice and you slide down the bottom, and then you have to climb again. So after 15 years of bumpy journey, bumpy career in UK, I finally sort of crept up to this position. And I'm happy to have this position in Sussex. And of course, better late than never. So my first project on global health was on non-communicable diseases in Mediterranean countries, where I was leading the ethnographic studies on health-seeking behavior of Syria, Turkey, Tunisia, and Palestine. Palestine was already kind of struggling with its chronic crisis. But soon after this project started, the whole region was engulfed by political turmoil and also war. And our colleagues in Syria, they had to leave the country. Some of them died. And these colorful souks in Aleppo, where I frequently visited, were completely destroyed. Hospitals were destroyed. And many of our patients, NCD patients of the project, died just because of the lack of medical supply, what they will call collateral damage. So I witness how war is the social determinants of health. I read about necropolitics, but I have witnessed what necropolitics is, politics of death. And we had to shut down the project. And then I looked for new opportunities, and I joined, at that time, Glasgow End-of-Life Care Studies Group, which was led by Professor David Clark. While I was studying academically the social and historical aspects of death and dying, a personal experience actually transformed my perspective. It has a deep, kind of profound impact on me, because at that time, my father died from terminal cancer. I was very emotionally close to him, and he was my literary inspiration, actually. And soon after, my mother also died. I thought I was prepared for the death because medically I know that both of them were in an irreversible condition. But when they both passed away, I realized that I was not ready at all. And this, I mean, I have studied death from a distance, but this very intimate experience of death, dying, had a profound impact on me. And also, I read about total pain, physical, social, psychological, and spiritual pain. But I have an intimate experience of what total pain is. Also, in Bangladesh, palliative care is still not developed enough. So I had also it's a struggling experience to provide palliative care to my parents. And there are ICUs, which is very costly. And I've seen in a market economy how death is also a business. So this all has had an impact on me, and I took a special interest in death, dying, and end-of-life care. My first project on end-of-life care was death, dying, and end-of-life care on Syrian refugees in Lebanon. This was also inspired by my experience with my Syrian colleagues who actually had to leave the country during the project. What I realized that although there are lots of studies and resources around humanitarian studies and palliative care studies, but death is marginalized and neglected from both the field. The palliative care studies don't focus on death of the refugees. On the other hand, the humanitarian studies don't focus on the death, dying of the refugees. But what we found that the death and end-of-life care is a very crucial juncture in the migration journey of the people. And it poses a very unique kind of challenges, because they need to negotiate between the expectations of home, of origin, and the expectation of the host country. Me being a migrant myself, while we were doing the study, I could relate to a lot of this challenges of this whole sense of having home and not having home. And we have seen the extraordinary adventures people are taking to bury their loved ones just in their own soil from a different country. So it was absolutely adventurous, risky travel just to put their loved ones in the soil of their origin. Again, this issue of tension between universal and particular was quite prominent in this particular study. Death is, of course, an universal experience, but the way it is experienced, way it is managed, is hugely contextual. End-of-life care movement actually, it started as a social movement, but then it became a human rights issue as well. So the Dame Cicely Saunders, who is the founder of the hospice movement in the UK, once said that the terminally ill people, while dying, are nevertheless still living their lives, and it is important that they continue to live as social beings until death occurs and experience a good death. But as I've just said that death is an universal experience, but the idea of good is very relative. So the good death is a contested idea. I recall attending the first death cafe in a Scottish village. Those who are not familiar, so this is a movement where people are encouraged to come to a coffee shop, drink tea, eat cake, and talk about death. So this was also quite an surprising experience, but interesting experience for me. I remember in one of those death cafe, I asked one of an elderly couple, a Scottish couple, what worries you most about end of life? Without hesitation, the husband told me that I feel terrified with the idea that I will have to depend on someone else for my everyday care. And the wife nodded in agreement. But this response reminded me a conversation I had with my dying father. One day I was cleaning my bedridden father and asked him, do you feel embarrassed to rely on me like this? He smiled and said, not at all. I'm rather happy that I give you an opportunity to take care for me. And I can now die peacefully knowing that my eldest son was with me during my final days. And I would not say this is an exceptional view of my father. Many people probably in Global South would feel like that. So this very different perspective highlights the deep difference in the understanding of good death in Global South and Global North. But I must also say that the Global South and Global North can be a problematic categorization. I will interchangeably use Western, non-Western, but I'm mainly using the term to refer to the political and economic divide between countries and linking it with the colonial legacies. But this is also to note that most of the studies on end-of-life care, good death, almost 90% of the studies have been done in Global North, in Europe, America, and Australia. So we know more about what it means, good death in Global North. And the literature tells us that these are some of the attributes of good death. Being in control, being comfortable, sense of closure, preference for dying process, and pain-free status. Being in control, having the highest frequency. But on the contrary, in Global South, there are different kinds of attributes are mentioned. For example, in South Korea, a preparation for dying, avoiding meaningless extension of life, maintaining dignity and family interactions. In Bangladesh, dying at home in the presence of loved ones was considered as good death. In India, not telling the terminal diagnosis to the patient as a sign of love and ensuring good death. Some of you might have seen the movie Farewell, where a Chinese, American Chinese family actually visited their grandma in China in a disguise of a wedding to say her goodbye because she's going to die in a few months. And everyone except the grandmother know that she will be living only for a few months. So it was probably quite difficult for many people to kind of absorb this, but this is a reality there. Or like in the way Ghanaians celebrate death with coffin arts. So this is a coffin in the shape of an aeroplane. There are different kinds of coffins in the shape of Coca-Cola bottle, shoe, even car, because they believe that life continues after death and the person should live in style. Now, of course, if we see the difference in the perspective of global North and South, this is not absolutely strictly binary. There are overlaps, but there are very distinct preferences. So broadly, in the literature of Global South, staying control of your own life and death is a prominent kind of notion, which is linked with the idea of autonomy, choice, and individualism. And euthanasia is probably the ultimate example of having control of your own death. And it's not surprising that the approval of legal approval in euthanasia and debates of euthanasia is mostly or almost exclusively in Global North. In Global South, there is a strong sense of community and family, a collective and relational self. But that's not to say that there's no role of family in the Global North or there's no individual interest in Global South. Authors have studied and analyzed the complex historical processes behind this whole sense of autonomy and in the Global North. And this has also to do with the whole industrial development. Whereas, and for example, Hofstede discussed how certain society nurture the I consciousness and other society the we consciousness. And this is to do with history, mostly the historical process the society developed. For example, in this Rwandan proverb that when you are well, you belong to yourself, and when you are sick, you belong to the family. This also based on the philosophy of Ubuntu, African philosophy, which emphasized that you need another human being to become a human. But of course, this is nothing specific to Rwanda or Africa. This is kind of, I think, every humankind would relate to this. And in those contexts, it's the people are depicted not from the perspective of independence, rather from the perspective of interdependence. Again, this is to do with the historical process that certain society has historically turned into like nurtured a certain notion. And we also have to remember that when we talk about choice, you need to have options to have choice. So without the options, there's no question of choice. And in some context, interdependence is kind of a structural norm. It's an inherent structural norm. Because there are not other options, you will have to depend on, there are no other institutions. You'll have to depend on family is the core institution. I remember when I was working as a doctor in a Bangladeshi village, one day one family came, a husband and a father and mother, and a son, an adult son of 20 years. So I asked what happened. It was the father who was narrating that how the son fell from the tree and broke his leg. And then I asked, where is the pain? And it was the mother who was showing me that, yeah, here is the pain of my son. And the son was silent. Now this might sound that where is the autonomy of the son? And how does autonomy work? But I could see and feel and know that in these contexts, suffering is not individual. It's a collective suffering. And also, it's because they have to be interdependent, and that is family is the only kind of institution there. So we need to have a deeper understanding of how is depending or interdependency always compromising with the autonomy, or are there ways that autonomy is negotiated in a certain way in those contexts? If we look at even in the global north context, where independence is celebrated, how far and how long can we really celebrate independence? At one point, one could is ready to sacrifice independence. So these are very fine lines, and with this whole issue of dementia and other complex human situations. So you enjoy your independence choice with your able body. When you don't have that able body anymore, how far, how long can you enjoy and exercise autonomy? So these are also questions to think about, ponder about. So when I'm talking about dependence, independence, there are nuances, but there's still long way to explore these issues. And these issues have direct implication for global end-of-life care issues as well. When we look from global health perspective, it has implications in global end-of-life care, because death, dying, and end-of-life care is going to be a major challenge in 21st century. In the current trend of 56 million deaths per year is going to rise to 91 million by 2050, and most of these deaths will take place in low and middle income countries. And there are implications of deaths associated with new infectious diseases, HIV, AIDS, multi-drug resistant TB, complex humanitarian emergencies, including war and migration. And there are huge global differences. So different countries are at different demographic stages. Some countries are having more older population than the other. Countries are at different levels of health system preparedness. Very few countries in the world where palliative care is incorporated in the mainstream health system. 92% of the medical morphine is consumed by global north. And there are different local moral worlds about death, dying. I mean, a society that believes in afterlife and a secular society would have a different understanding of death and dying. And of course, we know about the different political legal system around euthanasia, assisted dying, and so on. And as I just mentioned, that there is a huge, almost 90-10 divide in terms of evidence. So only 10% of the studies on end-of-life care and death, dying has been done outside Europe. So given this difference, how the countries are managing the deaths of their members, because that is one of the responsibility of any society. The Economist intelligence unit tells us which countries are doing better in terms of managing the deaths. So they have ranked 80 countries based on 5 criteria: palliative care environment, palliative care quality, human resource, affordability, and community engagement. And based on those criteria, they have ranked 80 countries. And it's interesting, UK is they have told us that UK is the best place to die, or they provide the best quality of death through the institutionalized and professionalized clinical palliative care model. It's good news, probably not that good news. There are kind of stories behind the stories. Although UK is celebrated to having the best quality of death, but there are lots of paradoxes and contradictions. Majority of the UK people do not die at their preferred place, which is home. People, although this has the best palliative care system, but people want to die at home. And Care Quality Commission report argued that a process of medicalization is taking place within palliative care, overriding its early, more holistic intentions. And there are ongoing debates in relation to the ethical, moral, and legal aspects of assisted dying and euthanasia. We know that it's in the bill has been raised in the parliament. And also the Black, Asian, and minority ethnic groups in UK have much lower access to palliative care services when compared to white British people. While this model, institutionalized palliative care medical model, is celebrated worldwide, this kind of debates don't get attention outside UK. So I remember attending a meeting in the palliative care center in the only medical university in Bangladesh. Bangladesh ranked actually 79th out of 80. So there was a palpable sense of embarrassment among the palliative care practitioners, and they were discussing how to raise their ranking following the British model, UK model. But here is the key question. Is it both feasible and desirable to implement an institutionalized, professionalized clinical palliative care model like that of UK in Bangladesh and other countries in the global south? Is it at all possible with the historical and institutional preparation of the difference of the preparation of these two countries? Is it at all feasible, or is it at all desirable? Because the other study also shows that the conventional palliative care model, like this institutionalized, professionalized, medicalized palliative care model, actually catches the need of only 12%. So we need a different approach to, palliative care is also considered as a part of universal health coverage. So if we want to comply with universal health coverage, we need a different approach. But there are approaches. For example, Alan Kelleher proposed this compassionate community model, where he argues that end-of-life care should not be the responsibility of only the medical and social care services. It should be everyone's business. And he sort of proposed this community development participatory palliative care model. Although he conceptualized in UK, but the most successful model of palliative care, compassionate community palliative care, has been acknowledged as this one, the Neighborhood Network in Palliative Care Kerala, which is considered to be the most successful compassionate community model and a community-based model, where the palliative care is done by the volunteers. So they ask the community people to volunteer just 2 hours per week to care a bedridden patient in their community. They train them, and this is done through a wide network of volunteers. And they also have referral center for palliative care institutes, but they have reversed the pyramid of care, where the palliative care specialists play a very minor role. Now, I have conducted case studies of the Kerala model and also the similar kind of model that has been implemented in other parts of India, also in Bangladesh. And what we found that it's probably less challenging to implement this idea because there are certain so-called weaknesses or limitations in this society. There is no heightened sense of privacy. You don't need all sorts of legal approval to enter into people's house. Every step of life is not dictated by legality. The health system is not absolutely formal. There are informalities where informality can also play a role. And people, based on like social capital, a network of the community, network of the family. So this was relatively successful. And as I said, in the whole Kerala, they have replicated this model. They have also replicated in West Bengal, in Bangladesh. But while I'm saying that, but I also have to clarify that while I'm saying that this depends highly on the family and community, that not to romanticize that the family and community is very homogeneous and without any conflict. There are conflict. For example, the Rwandan palliative care physician, Christian Nizimara, he developed a concept of safari model of end-of-life care, where he talks about, through animal metaphors, he discusses how there are lions in the family who dominate, there are hyenas who do harms, and giraffes with elongated ego within the family. But given that situation, you can still give end-of-life care, keeping family as the center of palliative care provision unit, because still family is the main institution where people rely on during their time of crisis. So there are models how you can kind of leverage on this social capital. So community development models is a very strong counter-narrative of the institutional specialized model. But there are very little research on this, very few funding. You would not hear much about community development models. It's interesting also to note that in the 5 categories that I mentioned about ranking the palliative care, community development had the least weightage in the ranking. If the community involvement had a different weight in the ranking, the whole ranking could have been changed. So, for example, Bangladesh runs 2 quite unique community development projects, which is quite challenging but very unique projects. But they are still very embarrassed because they don't have institutional palliative care model, and they look for the future. Someday they will have this. So if we zoom out from this, one might ask that whether does the Economist ranking impose the model, like northern model to southern model? Like do they impose that the southern countries should follow the northern model? Of course, explicitly they don't do it, but they set up a benchmark which is qualified, which would be called a good quality death. That's the benchmark they set, and there is an underlying assumption that all the countries who are and all the bottom ranking countries should aspire to have this model of the upper ranking countries. So that's the assumption behind this. And this is how, long ago, Foucault told us about the power of narrative. This is about narrative. So dominance is maintained not through explicit mandates, but through discourses which shapes norms and societal expectations. So the models, the perspectives, the knowledge that has been developed in the West, nowadays it is not forced to non-Western countries through, like in the days of territorial colonization. This is done through colonizing the mind, which Mignolo called coloniality of power. So if we zoom out from the end-of-life care, and we'll see that this aspiration to have a good death, like an European model of good death, is also interlinked with the aspiration of European modernity. The post-colonial thinker Dipesh Chakraborty noted that how modernity is considered or conceptualized as has originated in Europe, and this is fully modern, and rest of the world outside Europe or the West or North, they still carry pre-modern elements. So they all are waiting in an imaginary waiting room of history, and their mission is to follow the West and catch up with the West at some point in time in the history. So they are all suffering from a not yet syndrome. So they are not yet modern, they are not yet ready to have a good death, unless you have the model of the Europe. And all this perspective is based on the limitation, the weakness, and lackings of so-called non-Western countries or global South. And it also creates a deep sense of inferiorization. And that's been going on. And that's where this whole issue of decolonization comes. It's nowadays decolonization sometimes become a intellectual fashion. It can be a metaphor. Sometimes it's kind of confused with equality, diversity, and inclusivity. But it is fundamentally it is about to challenge the portrayal of Western thoughts as a universal standard, inherently superior and desirable, while critiquing the enduring influence of colonial power structure. So it's mainly about having a plural vision of life. There are different ways, could be a different vision of life, and based on different knowledge structure, which has been, I mean, we know genocide, but there has been epistemicide, like a structurally destroying the knowledge system of various non-Western societies. So decolonization talks about epistemic justice, bringing different ways of knowing the world and give a justice to have a different vision of the future of the world. And how would it look in the global, like a good death context? How would decolonizing good death would look like in practical terms? In a recent paper that I have just published, I propose that good death has two components. One is value, another is logistic. So value is the judgment about what constitutes a good death, and logistic is the arrangement made to achieve this value. So if autonomy, pain-free death, and choice is the main attributes of value, then you need a certain kind of logistics. You need this very systematic, professionalized, medicalized palliative care model. But if the value is different, if the value is this relational self, even enduring pain is part of death, then you need a different kind of logistic. So I'm just sort of proposed a framework for value logistic end-of-life care, framework for value logistic of good death, where I suggest that we need to revisit the normative expectations about good death, and then need to adopt a contextual care model. And for that, we also need to, the global North and South should work together. It's not about delinking with global North. The achievements of global North or achievements of the Western world needs to be adopted. And I sort of mention more about epistemic fusion rather than epistemic delinking. So it should be mutual learning. For example, I know that in UK now they are adopting a lot of components in the Kerala model to implement a compassionate community here. And Kerala model actually also took the development of palliative care that has been kind of mostly taken place in the global West and translated it. So it's not transferring a model uncritically, rather than translating the model according to the context. So that is probably the future vision of end-of-life care. So that's what my argument is, that since there are plural ways of living in this world, there can also be plural ways of dying. We should not prioritize a certain model, certain perspective, certain thought process as the standard, as the universal. We should look for a pluriversal way of looking at life as well as death. So that was my main argument. I'm coming to an sort of end of my talk, but while I'm talking about these things, I am reminded of my father again. I would not say my father had a good death, because he wanted a death with the presence of all his loved one, particularly the children. Although I was with him for last few days, like many days in his final days, but I was not present when he passed away. But I know that he was fully prepared. He was prepared for the transition. He accepted his condition. I remember he used to tell me that, life is a beautiful lie and death is a harsh truth, and you need to accept both. And I know that he was ready for the transition. And he also recited me a poem from the famous Nobel laureate, Rabindranath Tagore, which says that death is not extinguishing the light, it is only putting out the lamp because the dawn has come. Maybe that's not true, but poets are supposed to keep our spirit like positive spirit. With that spirit, I would like to end my talk, and thank you for listening.